Good morning.
Good morning, Doc.
Okay, so naririnig niyo ko? Nababatian ako? Can you hear me?
Yes po, Doc, we can hear you.
Yes,
po.
Doc.
Okay, kayo rin man. Ano response? Nalilipat ang hininga mute and mute. Okay, so today we're going to have the lecture on malaria. So you're supposed to have lecture with Dr. Pulidario this morning, but I requested for a swap in the schedule because if we will have the lecture on Monday, face-to-face mode, maiiba na ng EU time ang laboratory because today's lecture is quite long. This is supposed to be a two meetings ko yung lecture nga lump into one, so we will use up the whole morning. So anyway, don't worry, magbe-break tayo after ano. So if you note that it's malaria 1, tapos after that we'll have a break and then we'll have malaria 2. Okay, so on the 20th, this will be part of the third long quiz for the second long quiz for the first bi-monthly. Okay, and then also for the coverage in the laboratory lab exam up to malaria. So yun. So I requested for a swap in schedule because medyo madamo-damo ang aton i-discuss about malaria. Okay? So okay, so let's start. It's Holy Wednesday. So tomorrow ano na tayo? Break na, school break for the Holy Week. Okay, so malaria. So this is a parasitic protozoan disease. And ano ba to? Okay. And this is the most important of all tropical diseases. So the impact of malaria is more severe than that of schistosomiasis, which is another parasitic disease. This has a high mortality morbidity, and this one is widely distributed in tropical and in subtropical areas. So we are part of this. Okay, in Asia, Southeast Asia. So more death and morbidity from malaria compared to that of other protozoan diseases. That's why it's considered to be the most important of the tropical diseases. So 4 out of around 120 species of Plasmodium. So the etiologic agent of malaria is Plasmodium. There are 4 known species and then an additional one, a 5th one. We will discuss them later. This has high high mortality morbidity again. 4 out of around 120 species are commonly known to cause human malaria. So there are other species of Plasmodium, but we will be concerned only with the 4 species, and that's Falciparum, Vivax, Malaria, and Ovale, and then a 5th one, Knowlesi. So it's wide in distribution, global, all continents except the Antarctica. Why is this not working? Okay, so in order of prevalence worldwide, Falciparum is the most, pinaka-popular. Kumbaga sa presidential, si Bongbong Marcos siya. Then followed by Vivax, Malaria, and Ovale. So nearly all malaria deaths are due to Falciparum. And a 5th one, as I said earlier, a new addition to the block, a new kid on the block, that's Plasmodium knowlesi. it's a parasite of primate of monkeys that is transmissible to human. So it's recognized as a fifth cause of human malaria in parts of Southeast Asia. So the most common mode of transmission is through the bite of an insect vector, which is a female Anopheles mosquito. So in the mosquitoes has has different species of mosquitoes which can carry or serve as an insect vector for different diseases. But in the case of malaria, it's the Anopheles or the Anopheles species of mosquito. So it's Anopheles in the Philippines, it's Anopheles minimus flavirostris. That's the full genus and species of the mosquito. And why I say female? Why? What happened to the male? Miss Kuan. Mr. Wallace, ikaw tayo picture yan na screen. Why do you think female? Specify good. Female Anopheles mosquito. Why not male and female? Miss ano, hay na to Mr. Wallace. Are you around, Mr. Wallace? Kaya ano nga female mosquito? Anybody?
Hiralat na kagat, Doc.
Hiralat na kagat? Nakagat niya male.
Require it female ducking blood for reproduction.
Okay, that's good. Yun eh. You are
Pergamento duck.
Pergamento, that's good. So only female mosquito bites and sucks blood. Hiyalat nagkikinahanglan hindugo bampera. While the male mosquito does not feed on blood. Ano't kinakaon it male mosquito? How does this survive?
Nectar.
How does
Nectar.
Okay, from the plant nectars. Okay, very good. So only female Anopheles mosquito, not only female, only female mosquito bites. So kagton ka nga ni, may magsipsip pa mo magtindugo. It's a female mosquito. Okay? And the mosquito vector for malaria is Anopheles, female Anopheles. Okay. In the lab exam, when we used to have yung diri pa online, so pa diri pa naka PowerPoint and lab exam, a favorite question. And tapos most student cannot spell out the complete. Give the complete genus and species of the mosquito vector for malaria in the Philippines. So, kutublahan no pili, so rin na minimus flavirostris. But it's good to know. May dapat niya sumpay. Anopheles flavirostris or Anopheles minimus flavirostris. Okay. Then aside from the bite of a mosquito, malaria can be transferred from one person to another person through blood transfusion. So if you get a blood sample from somebody who has malaria and in that blood there are malarial parasites swimming in the blood, so you can get the infection. Okay, that's why when you donate blood, part of the screening procedure is being screened for malaria, screened for Hep B. Ano pa ito na-screen? There are 5 diseases which HIV, when you donate your blood, parang libre na rin, napascreen ka na yung blood. And then you can also get malaria by accidental inoculation, or another way is via the placenta from a pregnant infected mother with malaria, she can transfer the parasite to the fetus via the placenta. So these are the mode of transmission, but the most common is through the bite of an insect vector, which is a female Anopheles mosquito. Okay, so in the life cycle of malaria or Plasmodium, sorry, malaria is a disease. There are two stages. So it undergoes asexual as well as sexual stages. Okay, so the asexual stages or asexual type of reproduction is also known as the intermediate phase. And this phase of reproduction occurs in man. So in malaria, man is the intermediate host. We are not the definitive host because where the sexual reproduction takes place, doon ang definitive host. So in man, it's the intermediate, man serves as an intermediate host because in man, only the asexual stage of reproduction will take place. And we call that the term in of the asexual reproduction is schizogony. Okay, the product of schizogony are merozoites. So the schizogonic cycle in man are of two phases. We have the exoerythrocytic phase, and then we have the erythrocytic phase. So the exoerythrocytic phase happens or will occur in the hepatocytes, outside of the RBC. So we have the pre-erythrocytic phase and then the hepatocytes. While the erythrocytic occurs in the red blood cells. And then this, as a result of the erythrocytic phase, you will have gametogony, development of the gametocyte. So later on, we will discuss all the stages, how they became gametocytes. Okay. So, okay. We'll start with the exoerythrocytic schizogony. So it starts with the bite of an infected female Anopheles mosquito. So a infected female Anopheles bites man and introduces sporozoites. So that's the infective stage to man, the sporozoite, which is found in the saliva of the mosquito. These are spindle-shaped cells. There is an illustration at the uppermost corner of the slide. Those are sporozoites. Okay, so a single bite of the mosquito can inject thousands of sporozoites, and then within 8 hours, these sporozoites, when it bites you through your skin, it enters the blood, and then 8 hours, within 8 hours, it disappears from the blood to enter the liver cells or your hepatocytes. And then depending on the species, in Plasmodium vivax and Plasmodium ovale, some of this hepatic stage parasite will persist in the liver cells. They become dormant. And the term is, they become hypnozoites, which will resume multiplication later after a period of months or years. And these hypnozoites found in the liver cells that remains dormant, they are the cause of malaria relapse. So you have relapse in vivax and in ovale, but there's no relapse in falciparum because there are no hypnozoites in falciparum. Okay, so once inside the hepatocyte, the sporozoites divide asexually by fission, binary fission. So that's where the first phase of schizogony takes place or starts. So as a result of the schizogonic cycle in the liver, the result is a deformation of pre-erythrocytic schizons. Okay, just take note of this mga terminologies: schizons, gametocytes, trophocytes, hepatocytes. Okay, balik-balik lang to as we course along. Okay. Then what happens to the pre-erythrocytic schizons? It contains thousands of merozoites. So its merozoite would consist of a small mass of the nuclear chromatin and a tiny sphere of the cytoplasm. So that's why I did not want to have the lecture on next week, Monday. You will get to see a lot of stages of the parasites, especially with Plasmodium vivax in the lab. Kasi kaparte to exam natin. And you have to identify the merozoites, the chromatin, the cytoplasm of the parasite. So when that schizons matures, it will rupture and it releases what is inside the schizons are the merozoites. Okay, so the merozoite now will enter the blood and attaches to the RBC by means of the surface receptors, penetrates your red blood cells, and the next step is the beginning now of the erythrocytic schizogony, or the asexual cycle in the blood. Okay, so once they're inside the RBC, the parasite resides in a vacuole, develops into, again, same stages that develops in the liver. It starts with an early trophocyte or the ring form. It matures, becomes a mature trophocyte. The mature trophocytes develop into an early schizons, and then develop further into a mature schizons, and when it matures, it ruptures and it's released into circulation. So the parasite will grow and fed on hemoglobin. That's why in malaria, one of the manifestation or clinical manifestation is anemia. So depending on the species, will be the severity of the anemia caused by the malarial parasite will depend on the species. Okay, so because it feeds on the hemoglobin. Okay, so as a result of degradation of your hemoglobin, you will have hemozoins or malarial pigments. Okay, so these malarial pigments are found in cytoplasm of the growing malarial parasite. So after 24 to 36 hours within the red blood cells, you will have the second phase of schizogony, or we term that as blood schizogony, because we have a hepatic or liver schizogony. So again, same stages, the mature schizon ruptures, releases the merozoites. Depending on the species, the number of merozoites inside a mature schizon. This is one diagnostic and characteristic, and these are seen in peripherals in the smear of vivax. The other stage, vivax, ovale, malaria, except for falciparum. We rarely see these stages in falciparum malaria. We will get to the reason later when we take a falciparum. Why? So as the schizon rupture, it releases merozoites into the bloodstream. Okay, so this rupture of the schizon, mature schizon, it corresponds to the time of the rupture. I mean, it is responsible for the febrile symptoms in malaria. So the febrile symptoms in malaria occur at the time of the schizon rupture. So this is implicated as the cause of fever. Okay, so the manifestation in clinical malaria is the patient will have a cold period, cold stage, and then a febrile, and then a sweating stage. So the rupture of the mature schizon corresponds to or is implicated as the cause of fever. And this is due to the release of a toxin known as cachexin, which act on the host cell, releasing a tumor factor. This is cachexin. So erythrocytic schizogony becomes synchronized, producing the classic febrile paroxysms of malaria. Okay, so in Plasmodium vivax, ovale, and malariae, schizogony occurs in the circulating blood and are commonly seen in the peripheral blood smear. So you will get to see in the slide a growing schizont, an early schizont, a mature schizont, and early growing mature. But in our case, in our lab, it is already good that you can identify a schizont. Commonly, I do not put up on a lab exam an early schizont. An early schizont is from a mature trophocyte. You have only one chromatin, big chromatin dot. That chromatin dot divides into a merocyte. We term that early, and chromatin that divides into two individual merocyte. Early pa yan. And then as the number of merocyte increases in number, we term that a growing schizont. And then when it has attained its full number, exact number of merocytes, we call that a mature schizont. So in the lab, schizont na lang. No need for an early, for a growing, just a schizont. If you're asked to identify stage of that parasite, that's schizont. If you think that's a schizont. So, okay. But for falciparum, schizogony occurs in the capillaries deep within the body. So that's why we cannot see these schizont stages in the peripheral blood smear. So for falciparum, what we will only see in the slides in the lab are the early trophocyte stage, that's the ring stage or early troph, and then the gametocyte stage. So the other stages of development, you will not get to see a mature troph in falciparum nor an early growing and a mature schizont. What they will see only are the ring form or the early trophocyte and then a gametocyte. Okay, because the schizogony occurs in capillaries deep within the body. So since there is no parasite that remains dormant in the hepatocytes in falciparum, so they do not have relapse. So the term here is recrudescence. Okay, we will also discuss later differences between recrudescence and relapse. And what happens when the mature schizont ruptures, it will invade other RBCs. Okay. Okay, so this is, you have this illustration in our lab manual, but the one in the manual is not colored. Next time, I will try to ask the printer to have a colored picture para mas mahusay. Okay, so what happens after the rupture of the mature schizont? It releases the merocytes into circulation. So some of them will infect another RBC, and some of them will develop into gametocytes. So the gametocytes are now the stage of the parasite that are infective to the mosquito. So I highlighted the infective stage to mosquito are gametocytes. So if you look at the illustration, the first row is on ovale, malaria, falciparum, and vivax. So this is the ring form. Ano ba ito yun? Pointer. Ito pointer. Saan na ito? Kani. Pointer. Okay, so these are the ring stages or the early trophozoite stage. So it will that if you will notice the red dot and a bluish cytoplasm, so the structure looks like a ring. So the circle here represents an RBC. So when you make your drawings, again, the drawing should be okay. What we're showing you in the lab is a thin blood smear. So you have to draw the RBC, and inside the RBC you identify the chromatin dot and the cytoplasm in your drawing. So then the other one next one is that of falciparum. So if you see in falciparum, you have sometimes in one RBC you can see multiple infection. In the others, tag isa-isa lang. But in falciparum, you can get 2 or more of this ring form in one RBC. And this one is the Malaria and then ovale. Okay. Then the next stage is trophozoite. So from the ring, it becomes parang ring pa rin, but this one is a broader and a bigger, the thicker ring. Okay. So again, the trophozoite stage, may early troph, that's the ring, and then a growing troph, and then a mature troph. Ini growing troph ini ya. Because when it's a mature trophozoite, the chromatin the red chromatin enlarges, but you can differentiate that from the gametocyte, kay dinhi may vacuole pa siya pag didiwaray na sa gametocyte. So these are the trophozoite stage. So for falciparum, if you look at this, there are 2 rings inside the RBC. And then characteristic of Malaria is the appearance of this one. It looks like a band form, characteristic band form in Malaria, and then ovale. I don't think we have the slide of ovale in the lab. And then the next phase or stage is an early schizoid. So that chromatin red dot starts to divide, it becomes schizoid. Itong mga nag-scattered ni red. Okay, so in falciparum, you have again same. The chromatin dot in the ring divides and it acquires its own cytoplasm. So naging schizoid, early. And then the next phase here is mature. Pag mature na, you have more merozoites. Look at vivax, okay? So this is one characteristic to identify or differentiate the different species, the number of merozoites formed. Then this is for falciparum, but in the peripheral blood, you will not get to see these stages. So in falciparum, only this stage, the ring, and then the gametocyte in yung mga banana shape or sausage shape structure. So after the schizoid stage, with this one ruptures, some of the merozoites goes to infect another RBC and the others develop into gametocyte. Okay. So the gametocytes now are taken up by the mosquito. That's why these are the infective stage to the mosquito. Then the microgametocyte undergoes nuclear division and matures by exflagellation, producing 3 sperm-like microgamete. And then the other one, the female, becomes a macrogamete. But these stages occur now in the mosquito. They develop into a micro and a macrogamete. Okay. So if you look at the 4 species of malaria, nila naiiba. Sometimes confusing. What we have in the lab, I think, are this one, the vivax and the falciparum. So this is a gametocyte, a male and a female. So macrogamete, female. In parasite or in protozoan as well as in helminths, the female are always bigger than the male. Madali pag hinumdum. Easy to remember. So once the macro and micro gametocytes are taken up by the mosquito. So when a mosquito bites an infected person with malaria, female Anopheles, so what happens is the micro and macro gametocyte goes into the mosquito and then develop into a gamete, no? And then pag naging micro and macro gamete, the male and female and they unite and a zygote is developed. Then the zygote develops as an ookinete. So they're motile and they penetrate the stomach of the mosquito. And in the stomach, the ookinete develops into an oocyst, and then the oocyst develops into a sporozoite. And then once naging sporozoite na siya, the sporozoites migrate and penetrate the salivary glands of the mosquito, and now it's ready to bite and transfer the sporozoite to a human being, a human host. Okay, so this is what we've been talking about, life cycle. So this is life cycle of the mosquito in a capsule. So I have several slides of this dinhi balik-balik and life cycle because I want you to familiarize, to internalize. Pwede kaya memorize the life cycle, because if you know the life cycle of the malarial parasite or Plasmodium, it's very easy to understand everything. So yun, this is an infected mosquito introducing sporozoites. So sporozoites are the infective stage of the human host. So within 8 hours, they are out of circulation, enters a liver cell. So in the liver, it develops. So this is what we term as your exoerythrocytic schizogony or your hepatic schizogony. So yun, in the liver cell, it develops into the trophozoite and then into schizon. Okay, then when the schizon ruptures, it releases the merozoites. Okay, so the merozoites now infects the red blood cells in circulation, and this is now the term now as the erythrocytic cycle or erythrocytic schizogony. So same process, same developmental stages. So starts with an early troph for the ring, then into a schizon, and the schizon ruptures and releases merozoites. So merozoites released into the bloodstream. Some develop into male and female, and the other goes to reinfect another RBC. The cycle goes on. Then a mosquito, here comes a female Anopheles mosquito biting an infected person. So what how's that? So again, in the mosquito, it develops into a micro and macro gamete, and then they unite to form a zygote, and then into an ookinete, which will penetrate the midgut or the stomach of the mosquito. So in the midgut, it develops into an oocyst, and then when the oocyst mature, it ruptures, releases the sporozoite, and into the sporozoite travels into the salivary gland of the mosquito, ready to infect another human being. So that's the cycle. So this one, easy. Iniliwat, this is the cycle found. You can see this na din, i-google mo sa CDC na ano. This is a more picturesque life cycle. So parang it's easier to remember also. So whatever life cycle you would like to remember, pareho letera. But this one is more okay, from the mosquito biting, bites, adi pagod habaga, nagbite. Then it goes within 8 hours, it infect a liver cell. So this is now the human liver stage or the exoerythrocytic cycle. Same. So it develops until it becomes, in 5 to 6 days, this hepatic cycle is complete. This caisson ruptures, releasing the merozoites. The merozoite goes to infect an RBC. So from there, it develops again into the ring. This is what we see in the peripheral smear, the ring form. Itong mga stages, you can all see this in the blood smear, except for in falciparum, wherein what we will see only is the ring and the gametocyte. So again, it develops, and some of this develops into a micro and a microgametocyte. And then when an iba, it ruptures and develop into and infect another RBC, so erythrocytic. So these are the gametocytes. These are the gametocyte of falciparum, and this one of vivax, ovale, and malariae. So taken up by the mosquito, and then naging micro and macro gamete, and then they becomes a zygote, and then an ookinete, and then in the stomach of the mosquito develops into an oocyst, and then a mature oocyst releases thousands of sporozoites, and they are found in the salivary glands of the mosquito. Another life cycle pa ito. So okay, so we do away with traditional names like benign tertian, malignant tertian, quotidian, kay confusing it here, confusing. So how did they come up with this name? Traditionally, it measures the beginning of the first paroxysm to this beginning of first paroxysm to the end of the second paroxysm. So like malignant tertian of subtertian malaria for falciparum, because fever occurs every 36 to 48 hours. And then why is it malignant? Because this one has a greater lethal potential compared to vivax. So benign tertian ng vivax and ovale because it causes mild fever and it's not as fatal as falciparum. So fever in vivax and ovale is 48 to 50 hours, while that of malaria is quotidian every 24. It will manifest as severe fever, but it's not lethal. Okay. So we are avoiding the traditional name because it's confusing. So what we do is the reason for that is the periodicity they imply sometimes fail to develop. I say every 36 to 48 hours. Sometimes it does not, especially in falciparum, especially if the degree of parasitemia is quite high. And then there is variability in paroxysm, febrile paroxysm cycle. Every 36, waringan mag-abot 24 pala nag-fever na. Or every 36, nag-abot 48 hours. Yun parang there is no parang consistency or regularity. And in the early stages of schizogony, there are multiple batch of parasites developing at different times. So that we said the fever corresponds to the time of rupture of the mature caissons and release of the sporozoites. Because of multiple batches, so sige may na-mature release. The following day, may nag-mature nag-release. So sometimes sige ka na lang nag-fever. So the initial cycle will vary and will not exhibit a specific periodicity. That's why we don't use the traditional name anymore. So the new system of naming malaria refers to the disease by its causative agent. Like say falciparum malaria, it's due to Plasmodium falciparum. Or a vivax malaria due to Plasmodium vivax, ovale, and so on. And malaria. Okay. So take note, when it's a disease, you add an E. Malaria. Malaria. So this is due to Plasmodium malariae. Okay, so sorry. So recognition of the malarial parasite. How are we going to recognize? We're doing a blood smear, okay? This is the easiest and the fastest, cheapest way to do it. So when looking at the slide, what are we going to look for? So these are the important things or structure. Chromatin. The chromatin is a red structure, the arrow below this one. The one in the middle, parang reddish pa siya. Okay. So this is a trophozoite growing, tika-mature na trophozoite of vivax. The cytoplasm is blue. So ini nga bagan nahimo nga ring. This is bluish in color in our slide. So when you try to make your drawing colorful, make the color appropriate. Color ng ibang color. The RBC, natural ang RBC is parang light pink ang color with the gimsa or the right stain. And then the pigment, they will not take up the stain, but they vary from golden brown to black ang mga pigments and malarial pigments. Then we have stipplings. Ito nga mga, in this arrow, points to stipplings. Ito nga mga that pinkish dot in the cytoplasm. So again, depending on the species, they are known as Schaffners, James, Zyman, Maurers. Okay. So for vivax, Schaffner, Malaria, Zyman's dots. This one for Falciparum. In ovale, you either have the term it Schaffner or James dots. I often get confused with the name of the dots of the stipplings with the parasite. So what I do is parang madali numduman. For Falciparum, Maurer. So ginano ko rin FM. FM Romualdez. So FM. Maurer, ang F is Falciparum, M is the Maurer's dot. So FM. Hindi naman MZ. Dumakod. Student, di ba may dad to? You were not around yet then siguro. Yung may MZ production na to, Tito. Big Soto ba yun? Yung mga Enting Kabisote, MZ production. So yun. Malaria, Zyman, MZ, MZ. So, dumduman mo lang nga duha. Ito nga duha. So, either karan vivax or ovale na hira. By way of elimination. Okay, pag oftentimes Schaffners, vivax Schaffners, pag especially during the exam noon, moving exam pa nga may from one microscope to the next. Sige, pala ko na ba ito nga ng kuwan, nagkarambol-rambol na. Yun. So next, again, another life cycle. So I found this in, so I like the illustration. So pare-pareho din ang explanation niya. But I like the illustration. That's how I try to remember things. Mas gusto ko may picture, may drawing. And I told the lab groups 6 to 8 last time we had the lab. I said, make your drawing naman yung do not be slighted or when I make comments on your drawing. I just want you to improve on your drawing, because if you make a different drawing from what is actually there, you will have a hard time remembering that during the exam. So ano lang, if I make comment, do not take it seriously. Joke lang, just to make you laugh and smile. But I commented once, kuya, ano't ngayon mo, amoeba, i-histolytic assist. Mga naman itong chinelas kadako. Di ba, the cyst around, and trophozoite land, bagat kuan, because of the pseudopodia, they have like an amoeboid, parang amoeba. Amoeboid, parang amoeba kay amoeba man. I-histolytic kada the pseudopodia, they have parang yung shape niya parang wavy something. But for the cyst, lidong itira lidong ay paghimuhin bagain bagain salbaro nga drawing. Ayun lang ka don't be slighted when I make comment. Ganun lang talaga ako. I want to correct and make sure nga you do it para mas easier for you to remember. It's not for my para taimo, para haak. Kaya ko I can identify that. Para imo. Then for malaria, I suggest you have a blue and a red colored pencil. Easier. So you color the chromatin red, the cytoplasm blue, and then the RBC slightly pink. So halo-halo. Kumbaga politika, may pinklawan, may red, may blue. Depending on your srimpahan mo political leanings. Para rin politika. Ang RBC pinklawan, ang chromatin red, ang cytoplasm blue, pakyaw yun. Madali mainumduman mo. Okay. So this is another life cycle. You can so that you will not forget. Importante ko yung life cycle in malaria, because from here I can ask you a lot. I can ask you a lot. You can learn a lot about the parasite and the disease, malaria. So smear. So in malaria, we make two types of smear, a thick smear and a thin smear. So the medtech know how is it done. On thick smear, yun lang, a drop of blood on the slide. You do not do anything about it. Well, for a thin smear, you put a drop and then you spread it. So this is advantageous for doing a screening procedure if you want to examine a large amount of blood quickly and easily. Madali, pag look after staining, look at under the microscope, you will see parasites, especially if you're doing screening in a community. Okay, so but in here you will not see the configuration or the morphology of the RBC. Okay, and then the parasite are distorted. That's the disadvantage. Distortion of the parasite. But if you want to see, there will be a lot of parasite in its field, unlike that of a thin smear. Sige ka pa, move this slide left to right, up and down to look for the parasite. While in a thin smear, this is a thin smear. So if in a thin smear, you will see the morphology of the RBC. So these are the RBC. And this is a parasite, okay? This one is a trophozoite of bivax. And so in a thin blood sample, one layer of evenly distributed cells. So they're in a kumpul-kumpul. While compared that to a thick smear on the right-hand side, ini nga mga dark blue structures, these are WBC, in my monocyte, lymphocytes, polymorphonuclear leukocytes, but the RBC, parang parang they are not, you cannot identify na, ini nga mga These are parasites na ito nga mga distorted lang. Oo. Sometimes ano waray ka di na klaro ang ring on the chromatin or the blue cytoplasm kain na. So what we will give you in the lab are thin smear. Okay. So what are the stages of the parasite to identify? So trophozoite or the ring form or the ring stage. These are the commonly seen stage of the parasite for all four species. You can see this in the slide. This one is vivax, falciparum. And this one is vivax. Ito from iniubale ade malariae. Depending on the stage, what happens to the RBC? Naging bluish in color, sustain yun. So if you notice, like in this case, falciparum, there are two early trophozoite or two ring forms, no? Two chromatin dot inside the RBC. While in vivax isa lang. And then the unstaining niya parang may significance then. You look at this one paler and the darker. Because in vivax, it infects young RBC. While in falciparum, all stages of RBCs are being infected. That's why the degree of parasitemia is high, the higher anemia in here. That's why this is more lethal or more fatal. Then we have in ovale, and this one in malaria. Ito ang amoy ng sinisay nga band form. So the chromatin dot and then the cytoplasm parang nag-spread siya to the side. It looks like a band, B-A-N-D, band. So ring may appear incomplete in thick film, and then the size varies, and usually chromatin dot only one, but in falciparum you can have two. Then the next stage to identify are the schizont. These are easily recognized. And the chromatin starts to divide into daughter cells. So in the ring form, you have, for trophozoite form, we only have one chromatin dot. When the chromatin dot starts to divide into daughter cells, we call it's now the beginning of your schizont stage. You have early schizont, a growing, and a mature schizont stage. So the daughter cells are termed now as merozoites. So ito nga bagan mga liso, just like ano ba yan? You cut a guava. Sabi na ang guava nga medyo mapula-pula ang flesh. So you cut that in half. Nakita ka na muna-muna liso. Parang mga liso siya. That's how I try to remember as schizont. Then the number of merozoites will help to identify the species. In the later part of the first part of this presentation, and then yung we'll get to that. Okay. Then the next phase is gametocyte. So in vivax, you have to identify this. You can see this in the smear as well as in falciparum. So the gametocyte now develops into either a male or a female. So these are falciparum gametocyte. So the black arrow is pointing to a macro gametocyte, and the other one on the to the left of the arrow is a micro gametocyte or a male. This is a female. So the difference is you look at the shape, parang banana, it's pointed at both ends, while blunt end and male or the micro. Then the cytoplasm is more compact than the male, in the middle of the parasite of the. But we will not go into those details. Just it's already good. You can identify one that is one is a gametocyte. We don't even specify in the lab if in the exam kung it's a male or a female. Basta gametocyte, maka-identify ka gametocyte, that's fine, that's good. Good na. Well, look at this. This is a Vivax macrogametocyte, a female gametocyte of Vivax. So the red arrow is pointing to the chromatin. So look, the chromatin that is quite big, and the whole cytoplasm now is filled. That's the ay parang bluish colored, and then damo an stipplings niya. So these two, you can see them in the slides. Okay. So ages of infected RBC. Okay. So in Vivax and in Ovale, they infect only young RBC. So you remember the lecture in physiology? What's the precursor cell in before it goes into circulation and becomes your red blood cell? What is the stage before this? Physio, nag-lecturehan blood last year, iyo. Who did the lecture, Miss? Or I will ask Dr. Paloma.
Retic, Doc.
Huh?
Reticulocyte.
Yeah, that's good. Correct. Nag-lecture ha iyo last time? Nag-lecturehan ano? Blood of physio. You still remember?
Ikaw po, Doc.
Ha?
Ikaw po.
Naka-lecture ako iyo?
Yes, Doc. 1 unit po.
Nakalimutan ako. Sorry. Ito to rin nakado. Ito kayo nakado. Kaya this year rin na ako Okay. So it infects only young RBC. So before, di ba, while they are in the bone marrow, it develops blah, 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 until maging reticulocyte in a few hours from once they're in the blood, they mature into an RBC. So we call them young. Kaya how many days ito lifespan ng RBC in circulation?
120.
120, correct. Remember pa ka mo. Okay. So, while malaria infects aging RBC, ang mga lagas liwat senior citizen ng RBC, mahapit na mag 120 days, tikalagas na, tikawara na circulation. So, this limits the number of RBC that they can parasitize to less than 3% of all RBCs in the circulating blood. That's why it's not, it can cause fever, severe, but it's not lethal, malaria. While falciparum, the difference is it can infect RBC of all ages, young, young, adolescent, up to matured RBC, up to the parang senior ng RBC, tanan, way pili, no? So the severity, the rate of complication and mortality increases in falciparum because of the levels of parasitemia also increases. So, more anemia, kay tanan man nga RBC, di man yan napili. While in Vivax, it only infect the young RBC. Medyo bata-bata. Ayaw niya ng matanda. Okay, so, asya na inira. Do not be, ayaw lang kahulog pini nga mga tabulation. So, just for lang. Like our size of RBC, so we said larger than mature, smaller than older RBC, smaller than older RBC and falciparum, larger than mature. The shape round, tanan, maybe crenated for falciparum and di ha ovale, oval, that's the oval and maybe fimbriated and MRBC. So when this characteristic refers to the RBC. Then cytoplasmic inclusion yun. Vivax, Schaffner's, Malaria, Zyman, amo to nga M plus Z, MZ, Malaria, Zyman's, falciparum, Maurer, so amo to. How I remember, FM, FM Romualdez, Falciparum Maurer. Then for ovale, Schaffner's or James Dutz. Then the next slide is on the ring forms, okay? So in Vivax, delicate ring, compact ring for Malaria, very delicate for Falciparum. Sometimes the cytoplasm is very thin. Makita na itong dot ng na red. And a dense ring for ovale. Then chromatin 1, tag 111. Well-defined mass in ovale, but fine dots gap in Falciparum and frequently 2. So you have 2 or more, 1 or more chromatin dot. Then applique or acoliform, frequent with Falciparum. Sometimes lang in Vivax. So pigment at this stage of the ring form, none. But in Malaria may be present, none for this. Then multiple parasitized cells sometimes, but frequent with Falciparum, rare in Malaria and ovale. So when you try to remember like this, guide lang, pag minimorya ng shape, delicate, compact, delicate, dense. Chromatin 1, 1, 1. What I do is, like here, delicate ring, pareho mga kwandilit masyado. So ini nga acoliform or applique form. Inilat frequently. Mga term like frequently. The others are none. Then pigment, warahira, except maybe at this point of early ring stage and Malaria and Maida. Then multiple parasitized cells, adika Falciparum. Parang ganun lang pag diri nga. Pagkakan parot na kay you'll get confused later on. Kalimot ka lahat po sa ito. May crumble na. Okay? May damo pa yun eh. Okay, so the developing trophozoites, the size of the large for Vivax, small in Falciparum, small in ovale. So Vivax large, dako siya. Because they infect young RBC. So the younger the RBC, diba, the bigger is the size of the RBC. Then as to the shape, very irregular, amoeboid, and trophozoite niya, compact. Anyway, we don't get to see this in circulation. Compact for ovale, porera compact. Nilaan irregular amoeboid. Then chromatin, dots or threads, very prominent for Malaria. Dots or thread-like in Falciparum. Large irregular clump in ovale. Then what else? Pigment. Pigment texture, pigment color. As I said earlier, the pigment ranges from yellow-brown to black. In Falciparum, the pigment is black in color. Okay. Okay. So from the mature schizont, in Vivax, it fills the RBC. Puno, nearly fills, pareho tanan, except for ovale. Then the shape segmented. So segmented, that means usa-usahira. One chromatin with its own cytoplasm. Puro segmented, except in here, characteristic for Malaria. Plasmodium malaria ito. Malaria. May particular arrangement siya, parang daisy head or rosette. An arrangement merozoites. Again, this one is the merozoites are, these are the number of merozoites inside a mature schizoid. For vivax, 14 to 24, an average of 16. For malaria 6 to 12, an average of 8. For falciparum, 8 to 32, an average of 24. And then for ovale, an average of 8. Usually, inila ng these two. 16 and vivax, and then for malaria 8 arranged in rosette or daisy head. Madali mag-identify. And this one is can be used to identify the species, the number of merozoites. Then you look at the RBC. Then pigments are seen in the center. For all of this, they are aggregated in the center. And yellow to brown to black pigments. Then the microgametocyte, or the male, they are round or oval, compact in shape. While in falciparum, hila nahawaan, different shape, kidney shape, blunt rounded ends. And then the cytoplasm is pale blue, reddish blue for falciparum. The chromatin mass single, and then here it's fine granules scattered throughout. Then abundant pigment granules all throughout in 4 species. Okay. So next is the shape of the macro and female gametocyte. Okay, round or oval. Again, pareho lahira. Then the different shape is that of falciparum. Crescentric, sharply rounded end, or some textbook will describe it as banana shape. Then the cytoplasm is dark blue in color. That's why I ask you to have a blue and a red colored pencil. May naman, di ba may dapawit ka sanhi? I remember, the other end is red, the other end of the color pencil. Sa lahi, the other end is blue. Pwede na lang yun. You don't have to buy, yung tawag ito, itong mga Stidler nga, kadadamo nga color. We do not need so much color here. Then the pigment, there are small masses around the periphery. The black rod-shaped granules near the nucleus, and small masses around the periphery. Okay, so that's it. We're done with the morphology of the parasite. Shall we have a break or we'll continue? Continue na lang, So we will finish early. So because I was planning to have 2 meeting lectures on this, but we are trying to catch up with, because of the mga holidays, mga suspension of classes. So yun, tutuloy-tuloy ta nila ini. Okay? So definition of terms muna. So what's a pre-patent? What's an incubation? So a pre-patent is the interval of time from the time that you get bitten by the mosquito and the sporozoites are injected into the human host to the detection of parasite in the blood. We call that as the pre-patent. So it depends, the pre-patent period varies depending on the species of the Plasmodium. Then the incubation is the period, is the interval of time between the sporozoite injection and the appearance of the clinical symptoms. So what are the factors that affects your incubation period? One is the dose of the sporozoite inoculated, so the number, and then the immune status of the host. And the host history of chemoprophylaxis. Those will affect the incubation period. Then relapse and recrudescence. So we said there is relapse in vivax, well, none in falciparum. So relapse is a recurrence of that takes place after a complete initial clearing of the erythrocytic infection because of the presence of hypnozoites in the liver cells. So this occur periodically, but irregularly over a period of up to 5 years. And it is due to reinvasion of the blood by the merozoites produced when hypnozoites awake from dormancy. Going back to the life cycle, that's why I said the life cycle is very important, because we said in the hepatic phase or the exoerythrocytic phase, some of the parasite will remain dormant in your hepatic cells or liver cells, and then they can be reactivated sometime after a period of some time, and then so they reactivate and develop and then becomes mature, releases merozoites, and the merozoites invade the blood. So that's the cause of the relapse. So because of the hypnozoites, reinvasion of the blood by merozoites produced when hypnozoites awaken from dormancy. While recrudescence, we do not call it relapse in falciparum. Instead, the term is recrudescence. It's a recurrence of symptoms in a patient whose bloodstream infection has been at a low level as not to cause symptoms. Okay, so we call that recrudescence. So what is the cause of recrudescence? It's persistence of the erythrocytic parasite in small numbers between attacks. So reinfection due to a new inoculation of sporozoites from a vector of fear and get bitten again. If untreated, it may occur from time to time for more than 30 years. Okay, then the fever, remittent, and remittent, intermittent. Okay, so remittent, daily elevated temperature of over 38 degrees centigrade. Then it returns to baseline, but not to normal within the 24-hour period. While intermittent or periodic fever, the temperature of more than 38 degrees is intermittently elevated. It returns to normal one or more times during the 24-hour period, intermittent. So you will have febrile, and after a few hours, no fever. And then after, say, 4 or 5 hours, I gave my child biogesic paracetamol. Balik mamandok ka, intermittent fever then. Continuous or sustained temperature remains elevated more than 38 degrees. Fluctuations of elevated temperature within the 24-hour period is less than 0.3 degrees. Okay, what are the clinical features of malaria? So during the liver phase or your exoerythrocytic cycle or phase of the malaria, there are no symptoms. Okay. But it's during the blood stage of the erythrocytic phase of the malarial parasite where symptoms are present. So you will have different signs and symptoms. So like the rupture of your schizoid, releasing the malarial toxin, it coincides with the febrile episode in malaria. So the common clinical feature in malaria are fever, which is irregular at first and it becomes synchronized after a week or more of the illness. Then you will have anemia due to hemolysis of the RBC hemolysis, and bone marrow suppression, and they are most severe. The anemia is severe in falciparum because, as we said earlier, of the degree of parasitemia infects all stages of RBC. So anemia is more severe because the parasite feeds on the hemoglobin. Then splenomegaly or enlargement of the spleen. So early in the spleen enlarges early in the illness in all types of malaria, whether you're having falciparum, vivax, ovale, or malariae. And then repeated attacks can lead to or cause hypersplenism. And then jaundice is also a manifestation in malaria. It's because of the hemolysis. So severe jaundice is seen in falciparum due to severe hemolysis, and you will have an impaired liver function. Okay, so the three stages of clinical malaria. So this is symptoms of malaria. So you have affecting the central brain, say CNS. You have headache, manifested as headache, especially with falciparum. You have cerebral malaria. Then fever, systemic manifestation. You have fever. Then muscular. You have fatigue, pain, and back pains. Then on the skin, you will have chills and sweating, a dry cough, enlargement of the spleen, and nausea, vomiting in the GIT. So these are, it could manifest in give us several signs and symptoms. These are the clinical stages. You have initially a cold stage. So patient will be feeling cold. Then it will be followed by a hot stage, and then a sweating stage. Okay. The total duration of the typical attack last is about 8 to 12 hours in stages. Then, but it can be longer in some types of malaria. Okay, so initially cold, in a hug coat. So patient is shivering. Maski parang a blanket. Start with an appropriate feeling of coldness and apprehension. We have, I think everybody has experienced this. So it starts with mild shivering, quickly turns to violent teeth chattering and shaking of the whole body. In Waray-Waray, we call this takig, takigan. But the core temperature is high. Then it is brought about by an intense peripheral vasoconstriction. And in young children, vomiting and febrile seizures may occur. Okay. And this one, paano ba ito this rigor will last for about 15 to 60 minutes, and then after that, the shivering stops. So after that, you will really feel exhausted, kapoy, the whole body shaking. Okay. Okay, the next phase is the hot phase or hot stage, also called the flushed phase. So patient becomes hot, headache, palpitations, and tachypnea, epigastric discomfort, nausea, and vomiting. Patient will be thirsty, temperature peaks at 40 or more, and the patient becomes delirious, flushed and delirious, so redness, namumula-pula, and delirious. And this one lasts for 2 to 6 hours. Then the third phase is sweating. So after the cold stage, you will have the hot phase, then the sweating stage. So the effervescence or the diaphoresis, so you sweat a lot, then the temperature lowers over the next 2 to 4 hours, and then the symptoms will diminish. Okay. Okay. Incubation as to a tabulation of the manifestation. Incubation period, an average of 12 days for falciparum, and 12 to 17 days for malaria, and it could even last up to 6 to 12 months an incubation for malaria. Ovalis 16 to 18. Sorry, this is for buybacks. And malaria 18 to 40 days. Erythrocytic paroxysmal cycle 48 hours. This was the basis for the old name of the malaria. 48 benign tertian, ito malignant. 50 hours for ovale and 72 for malaria. Febrile paroxysm, 16 to 36 hours or longer, 8 to 12, mas grabe lang, falciparum. Degree of parasitemia is an average of 20,000 to 50,000, a maximum of 200,000. That's per microliter of blood and parasite. Okay, inalain niya. Para ako na doon at hindi na importante nga number, basta ang falciparum more, higher degree of parasitemia. Then primary attack, severe and non-immune, often fatal, while the rest are mild. Then duration of untreated infection, 1 to 2 years in falciparum, 1.5 to 5 years for vivax, 1.5 to 5 years for ovale, and 3 to 50 years for malaria. Okay, next slide. Pistol. Ay. Kapoy na dito laptop. Okay. During the first part of this lecture, you said there are 4 species, but another one of the 120 species of Plasmodium, only 4 are known to cause disease in human, but there is a new one, the new kid on the block, who said it's Plasmodium knowlesi, and the disease is knowlesi malaria. It's malaria in monkeys, or a simian malaria, common in macaca. This is a species of monkey and other monkeys in Southeast Asia. So the first recorded naturally acquired case in human was in 1965 in southern China. We have this Indonesia, Philippines, kasali tayo dyan. Malaysia, Myanmar, Singapore, and Vietnam. It's an acrodendrophilic type because it lives or thrives on treetop habitats. So yung mga monkey, di ba? Then the Anopheles vector, or the mosquito vector, is capable of a monkey-to-monkey transmission. So from one infected monkey to another monkey. So monkey-monkey. And then the monkey also can transmit, it can be transmitted also from monkey to human. So it becomes a zoonosis. Okay. And then a human-to-human transmission. And then another one is a human-to-monkey transmission, or anthropozoonosis. Human-to-monkey. Or monkey-to-human zoonosis. Kung human-to-monkey, anthropozoonosis. Ano ba ini? Jesus. Nakakainis ka na. Ay, Jesus. Stol. Ano ba? Ano ba? Bising. Okay. So the Nalisi malaria has an incubation period of 10 to 12 days or longer. And the erythrocytic or the paroxysmal cycle is 24 hours, or it's quotidian. So febrile paroxysm lasts for 12 to 31 hours, an average of 20. Parasitemia is generally low and it varies. Primary attack is mild to very severe, and it can be fatal. And then duration of untreated infection is not yet defined, and it's not no release, no relapse, and no recrudescent noted with no relapse in B. Okay, so pathogenesis of falciparum, since this is the most fatal and serious severe infection, severe type of malaria. So this has the capacity to cause severe or complicated malaria. Mostly all malarial deaths result from falciparum infection. The pathogenicity increases because of its capacity to establish high parasitemia, infecting all ages of RBC. Then it can alter the surface of the infected RBC, and they can get sequestered or they can hide in the vascular bed in the deep structures of the body. So sequestration is a hallmark of falciparum. So what is being sequestered are the mature trophozoite and the schizont stage. Because the early trophozoite, yung ring form, we can see that in the peripheral smear and also the gametocyte form. So the trophozoite, mature troph and schizont are the one that is being sequestered in falciparum. So what are the organs affected by falciparum? So you can have a cerebral malaria, the brain, it can go and infect the lung, the heart, the bone marrow, kidney, liver, pancreas, intestine, and even the placenta. Can cross the placenta and infect the fetus. So what's the significance of the sequestration? It allows the parasite to avoid passage to the spleen. So avoid clearance by the spleen. We said the spleen is the slaughterhouse of the RBC. All RBC goes into the spleen. Okay, so it avoids passage to the spleen, and then it contributes to diagnosis difficulty. While for the other species, Vivax, Obali, and Malaria, they do not sequester, they do not cause microcirculatory blockage, unlike that of falciparum, because they are sequestered in the capillaries of your deep structures. Because the capillaries are the diameter, the lumen are quite small. So once they are sequestered in the capillaries, it can cause blockage, microcirculatory blockage. So there will be impediment of the, it hampers the circulation to a particular organ or structure in the body because of the blockage of infected erythrocytes. And rarely fatal with Vivax, Ovale, and Malaria, unlike that of falciparum. Okay, so the phenomenon of cytoadherence. So mature trophozoite and schizont infected RBC adhere to endothelial linings in the capillaries. That's a feature of the falciparum. It changes to the these are the changes to the red blood cell as the parasite mature. They becomes more rigid and less deformable. Diba? We said the RBC, they are parang a concave shape, so they can squeeze through small capillaries. But once they are infected, they becomes rigid and less deformable. So then there will be changes in their surface protein. So expression of senescence antigen, which will induce apoptosis or cell death, and then formation of nubs in the RBC. So what are these nubs? These are submembranous structure on the P. falciparum infected red blood cells, and this contains several proteins. So what are these nub proteins? You have the rositins, refins, your histidine-rich proteins, and your PFE-MP-1, or your Plasmodium falciparum erythrocyte membrane protein 1. It's the most adhesive proteins in the nub. So these are the proteins in the nub. So I highlighted this one. Okay? This is the most important, most popular, most adhesive proteins found in the nub. So what is this? Or it prevents the immune cells from producing interferon gamma. And what does interferon gamma do? It signals other immune cells to attack and destroy the infected RBC. So your nub, your PFE-MP1 prevents immune cells from producing interferon gamma. And then at the same time, it causes infected RBC to stick to the endothelial cells that line the blood vessels. This is an illustration of the cytoadherence. So these are the RBC. This is a capillary, and it adheres or stick to the endothelial lining. And this one, look at the disinfected RBC. It now blocks the passage of blood from in this structure, capillary structure. So rosetting is a spontaneous binding of an infected RBC to the infected RBC with mature blood stains in mature falciparum malaria. Okay, so the proteins that mediate rosette formation, you have rosettin and then the PFE-MP1. So what's the significance of rosette formation? High levels of parasitemia. So if you have rosette formation, that means you have high levels of parasitemia, and this is associated with disease severity, especially in cerebral malaria, which blocks the blood flow. It causes a blockage in the flow of the blood to a particular area. Okay, so what's the role of the spleen? It's important in protection against malaria. Yes. But in acute malaria, the spleen enlarges. Why does it enlarge? Removal of parasitized RBC from peripheral circulation, that's one factor. And your splenic macrophages removing the dead parasite. So a splenic individual may be at a serious risk from falciparum infection. Because if you do not have a spleen, your dead malarial parasite, they remain in circulation. They can cause further blockage. Okay. So we have this hyperreactive malarial splenomegaly or HMS. Formerly, this was known as your tropical splenomegaly syndrome. So the individual will show an excessive immune response to malaria. So it's manifested as a massive splenomegaly and hypergamma globulinaemia. So in cases or in persons with hyperreactive malarial splenomegaly, it is managed by giving long-term administration of anti-malarial prophylactic drug. And then splenectomy is contraindicated. So only falciparum causes severe malaria. So these are the clinical feature of severe malaria. It's defined as P. falciparum infection with one or more of the following. So severe generalized convulsion, unrousable coma, hypoglycemia, acute respiratory distress syndrome, pulmonary edema, renal impairment, hemoglobinuria, anemia, spontaneous bleeding, and acidosis. These are the features. They can also be a feature of other diseases, but in falciparum you will get to see this. Okay, complication. The most serious one is cerebral malaria. This can be very fatal. And then severe anemia, pulmonary edema, and then black water fever. Okay. Again, a common favorite question, black water fever. In black water fever, it involves the kidney. So patient will present with a dark urine due to intravenous hemolysis and hemoglobinuria. And oftentimes associated with quinine, giving quinine. Quinine is an anti-malarial drugs given to persons with G6PD deficiency. So they will have bleeding or hemolysis. So they will come manifested as a dark urine. And another complication is an acute renal failure. Okay. So in pregnant women and in children, malaria in falciparum malaria in pregnant women. Okay. Pregnant women, we have intrauterine growth retardation, IUGR. A low birth weight baby, or they can go into spontaneous abortion, stillbirth, preterm labor, maternal anemia, and maternal death. And while in children, it is considered a medical emergency, falciparum malaria in children. It's a life-threatening condition, and the most common presentation is seizure. And the most common complication is cerebral coma. Patient also will go into opisthotenous or opistotonic posture. And 10% of children who survive will have neurologic sequelae. Okay, non-immune protective. So P-Vivax is unable to infect red cells lacking the Duffy blood group antigen. Remember the lecture on blood? We have the ABO antigen, the RH. Then there are several grouping. One of that is the Duffy blood group. So it's unable to infect red cells without lacking the Duffy blood group antigen. So it accounts for the natural resistance of people in the sub-Saharan African region because they do not have this Duffy blood group antigen. Then individual will cycle cell trait are resistant to the lethal effects of falciparum. Then another condition that it's a protective factor, conditions like G6PD and beta thalassemia. Okay. So for diagnosis, Okay, the diagnosis of malaria should be suspected in a patient presenting with febrile illness in a malaria endemic area or coming from a malaria endemic area like in the Philippines, Palawan. The remaining 4 provinces, one that is Palawan, then the Sulu region, endemic for malaria. So coming from, say, a vacation, you're a non-immune individual coming from a malaria endemic area. Okay. So you have 1 or 2 weeks after you develop high-grade fever, the classic symptom, chills, fever, plus sweating, classical. So the gold standard for making a diagnosis is microscopy. It's important in coming up with a definitive diagnosis. And it's easy to do. You just take a blood and then make a smear. So the best time to get a blood sample is, actually the best time is at the height of fever, but you cannot extract blood while the patient is shivering, right? So, and then very febrile, convulsing. So after that attack, you make the blood smear between attacks. So the yield may be highest at or near the peak of fever. And then it's important to have an accurate assessment of parasitemia or to quantify the percentage of infection. So for vivax, obali, and malaria, all stages are seen in the peripheral blood by falciparum. Only trophozoite and mature gametocytes are seen in the peripheral blood. So again, it's microscopy. So you make a thin or thick smear, stain it with Gemsa or right stain. Then do a quantitative Buffy coat method. We don't do this. I don't know about the medtech. When I did the postgrad origami, we just did the smear. You can make may usa ka slide box na dako. The one with 2 rows of you put 2 rows of slides. You make thin and thick smear. And then malaria, there is now a malaria rapid diagnostic test. It detects Plasmodium specific antigen, HRP2 produced by trophozoite and young gametocyte, and Plasmodium LDH produced by both sexual and asexual stages. Then aside from that, we can do serologic tests like indirect hemagglutination, indirect fluorescent antibody technique, and then the ELISA method. And then do gene amplification by PCR. So clinical management of malaria. Successful management of malaria will depend on making an urgent diagnosis. Okay, especially if we're dealing with the falciparum, it's very lethal and fatal and severe. So you make an accurate clinical assessment. So history is very important. When patient presents, usually patient comes in because of the fever, the chill, the fever, and the profuse sweating. Okay, the rigor, and then you have to institute appropriate anti-malarial therapy. So you make an urgent diagnosis. So not just say, ay, kay lagnat lang yan. The next thing, yung pasyente waray na. You make an accurate clinical assessment and institute anti-malarial. So again, from this, you can make urgent initial impression, maybe. If you cannot do a blood smear immediately, from the history, the patient coming in or living in a malaria endemic area. And that's one criteria, one factor that we should consider. Then you make a blood smear. Then your medical treatment will depend on the species, on the severity of the illness, species of the parasite. severity of the illness, then likely susceptibility to anti-malarial drugs, then the age of the patient, and then the background immunity of the patient. So if the patient has had malaria before or has been taking chemoprophylaxis. So these are a long list of anti-malarial drugs. Okay. We will not go into detail, mga action, mechanism of action, adverse effect one. This will be taken up in your pharmacology class. Okay, so quinidine. Quinidine-containing drugs, these are from cinchona alkaloid. These are cinchona alkaloids from a cinchona, bark of a cinchona tree. Din makadto kumita Facebook. There's a mountain that grows these cinchona alkaloids. Okay, these quinidine drugs, this includes your quinine, the quinidine, chloroquine. These are derivatives of quinidine. Mefloquine, primaquine, halofantin. Then another group are the folate antagonists. So the HFR antagonist, we have the proguanil and pyrimethamine. Your sulfonamide antibiotic, sulfadoxine and sulfone. Sulfone is the one used in leprosy. Then endoperoxidase in here. Artemisinin and its derivatives. Then the others that has been used for as anti-malarial, doxycycline. This is a tetracycline. Belongs to the same family as your tetracycline. Proguanil, and then the atovacon or malaron. Ito ba yun? Ano nila? Can be used for COVID. Okay. So in uncomplicated malaria, oral medication is sufficient. So tablet, they come in oral form tablet. Vivax, ovale, and malaria, you can give chloroquine. That's a drug of choice here. Then chloroquine resistant. So there are already chloroquine resistant Vivax. So an alternative is to give Malaron or an oral quinine or mefloquine. Then followed by eradication treatment with primaquine. Then for chloroquine-resistant falciparum, the drug of choice is quinine. Concurrent treatment with doxycycline or fansidar. An alternative drug is Malaron. So chloroquine-resistant has not been recorded in P. ovale and Plasmodium malariae. Okay, chloroquine. Okay, the chloroquine are active against the erythrocytic stage of most chloroquine-sensitive Vivax, ovale, and malariae, and also for the gametocytes of falciparum. This makes the pharmacological management a little complicated. And they can be used in pregnant and lactating women as well as in children in chloroquine. So its side effect is reversible corneal opacity and partial opacity. Then for quinine, this one is from the bark of cinchona tree. The mainstay of treatment for falciparum. The side effects are cinchonism, which is manifested as nausea, dysphoria, tinnitus, and deafness. Then hyperinsulinemic, hypoglycemia, and cardiac disturbance. The side effects of quinine. So for general management of severe malaria, you correct fluid and electrolyte imbalance, monitor renal function. You treat the hypoglycemia. You treat seizures for cerebral malaria. Try to rule out meningitis, okay? Because not all seizures are due to cerebral malaria. Oftentimes, but that's why history is very important Meningitis could be due to bacterial, it could be protozoal, it could be viral in origin or fungal in origin. Okay, so you have to rule out because the management is different. If you are dealing with a fungal cause of meningitis, you don't give chloroquine or quinine, diba? Then you treat anemia, you treat bacterial infection if there is a concomitant bacterial infection. Then you reverse the circulatory collapse, correct the volume depletion, and the use of ionotropes. Or in young children, you can do exchange transfusion. Okay, for severe, still chemotherapy on severe, parenteral quinine, quinidine, or chloroquine. So an alternative is you give artemisinin and its derivative mefloquine, halofantin. Quinidine is more active, more likely to cause cardiotoxicity. So you require ECG monitoring if you're using quinidine. Okay, for malarial relapse, primaquine is active against vivax ovale and ovale pre-erythrocytic stages. That means pre-erythrocytic yung sa liver phase pa to. So they are used primarily to eradicate parasites from the liver, preventing relapse. Diba? Because the relapse is due to the hepatocytes being that remains dormant in your hepatic cells. And they are also active, used for against P. falciparum, gametocytes of falciparum. So side effects of primaquine is GI disturbance. It can also cause cyanosis. Then acute hemolysis with anemia in patients with G6PD. So hemolysis and jaundice in G6PD deficient individual. And they are contraindicated in pregnancy. So in pregnancy, quinine is the drug of choice. Chloroquine has been used extensively with no specific adverse findings. Mefloquine appears safe when given in the second and in the third trimester. Pyrimethamine sulfa combination, pyridoxine, are used with caution. Excuse me. Ano?
Naglag sa igyan din po yung
Di,
focus barangay. Paray na.
ang bahay ano?
Pilar. Ang bahay ka to nga. Paray may na parabilin.
Okay, yan na lang. Nag-lecture pa ako. Yan na lang pag marites. Okay. Nagmarites nga. May ano daw. Baryo Abuyog nga na ano. Barangay Pilar. Naubos na landslide na tabunan. Parang din sa Ugod siguro. Kaluoy naman. Ay, nakita dito. So, malaria and pregnancy. Okay. The combination of pyrimethamine and sulfa are used with caution. So, you stick to quinine. That's the drug of choice. And doxycycline and primaquine are contraindicated in pregnant women. The reason for that, I learned this when I was also like you. I was in the second year medicine. Ano pa to? Tetracycline pa. Kaupulinate family ng tetracycline. This is contraindicated in pregnancy and lactating women and in children below 8 years old because of bone deposition and discoloration of the teeth. And makurito, the children will grow up having yellow colored teeth. So chemoprophylaxis is the giving of the drugs, parang preventive, involves regular administration of the drug to prevent clinical symptoms. So action of chemoprophylactic drug, they could either be scienticides or against the schizons. So we call it scienticides. They destroy the parasite when they enter the RBC. And another is the causal prophylactic. It prevents development of pre-erythrocytic schistons in the liver. They may also have a blood scinticidal effects. So when is chemoprophylaxis indicated? So they are routinely advised to persons who are non-immune traveling to an endemic area. So you want to go to an endemic area in Palawan. Not all of Palawan naman. But still Palawan reports the highest number of malarial cases. Or pregnant women in endemic area to reduce placental malaria and low birth weight babies. Then sulfadoxine or pyrimethamine combination given in 2 doses as prophylaxis. Ay, So this another prophylactic drugs, the proguanil. It's a slow-acting scinticide and causal prophylactic, safest of all anti-malarial drugs, the proguanil. Then you have the atobacone proguanil combination, effective against chloroquine-resistant P. falciparum. It is classified as a causal prophylactic. Then doxycycline, useful in areas where there is resistance to both chloroquine and mefloquine. And mefloquine has this adverse neuropsychiatric side effects. Okay, we're almost done na. So epidemiology, malaria in the Philippines. It used to be endemic in 58 of the 80 provinces, and nearly 12 million people were affected. This is the WHO 2010 report. So 13th of the population are at high risk. 2010 pa yun, 2022 na. So may improvement na. In fact, DOH has that we are going to eradicate malaria. It's not only malaria eradication by 2030. So most malaria cases in the country occurs in forested, swampy, hilly, and mountainous regions. So the majority, or 72% of cases, are due to falciparum, and 26% to vivax, while 1.3 are due to other unspecified species, and 0.7 are mixed infection. The principal vector in the Philippines is Anopheles minimus flavirostris, which breeds in clear, fresh water streams in foothills and mountain slopes. Okay. So it's Anopheles minimus flavirostris. That's the principal vector. So these are some of the provinces where there is no risk for malaria. Kasama tayo dyan. So you can go to Boracay, according to Boracay, to Bohol, in Bohol, Catanduanes, Cebu, and Leyte. There is no risk for malaria. So you can go to Panglao in Bohol, to Boracay. You can go to Cebu, Leyte. Hindi ka magka-malaria. Ito ka Leyte yung kasisto ka lang. In some areas, not all of Leyte naman. Okay. So this is the malaria map in the Philippines. In 2014, this is it. Ito ang mga red area. Di na ini klaro number of cases per 1,000 population. Basta ini nga red area. This was in 2014. Ito 2014 ito. Guti na la. Asya na la ni Palawan. Ini nga Sulu area. Ada ini. When in 2003, okay? You will note that madamo pang pula di North Luzon, di pa di ano yung area din it Mapa Marinduque, ano ba di Palawan, ini Palawan, this is in Mindanao. So damo pa Mindanao from Surigao, ini di may Butuan, Davao, ano pa ini din yung area. Okay. So now DOH has target ng DOH by 2030 we will be malaria free. So the existing provinces with still reporting a high number of malaria cases are Palawan, Sulu, Occidental Mindoro, and Sultan Kudarat. But Sultan Kudarat siguro ini Mindanao, this area here. And this is Sulu. Yeah, okay. So these are the provinces in the country. Palawan, Sulu, Occidental Mindoro, and Sultan Kudarat. Okay. So globally, look at the global malaria map again 2010 ini from WHO. So the red ones are the country who's trying to control malaria. The green ones are free, malaria free. Ato ka Russia, wari malaria. Russia, pwede din yung mga lugar. And this one is in America, the North America. Wari malaria. So these are malaria free area, Australia. While the light blue are eliminating malaria, China. Look at the Philippines, blue na kita. There are dark blue areas which are malaria free, and then the light blue are areas where malaria are being eliminated. While the red one are trying to control malaria. This is part of Southeast Asia, Thailand, Vietnam, Cambodia, Burma, Indonesia, and in Papua New Guinea, near Australia. I remember sometime in 2012 ba yun? Somebody recruited me to go to Papua New Guinea to teach. They were all opening a school School of Nursing. They were offering me to teach microanatomy, microbiology, and parasitology. Then when I Google Papua New Guinea, malaria endemic man ini. Said ko, okay, parang I had second thought of going. I said, mamatay naman ako dito malaria. Makita ko kwarta pero namatay sa malaria, wag na. Okay na lang didihan. Go to Cebu or go to Cebu or dinin lahat Tacloban, why malaria? Not yet. I'm still having a class. Wait. So there are 100 countries and half of the world's population are at risk. So these are the countries which are, or the areas where it's at risk for malaria. Africa, Southeast Asia, Central and South America, Caribbean, Southeast, Middle East, Southeast Asia, and the Oceania. Ang minirat places. So, pagsaring Pilipinas mas damo pa malaria. You go to Thailand, kanagpurula lang Thailand. When I did the postgrad in Thailand, and tropical disease hospital, parang at the time ang admission, parang the whole floor, parang puro malaria. So we did we had a time doing the smear. ikaw lang, mapira ka box ni mo nga smear. Kapoy lang kayo magsige ka stain. Damo kay malaria, cerebral, may pregnant, may children, may every ano. Parang the whole, parang sa ka-building, puro mga malaria ang pasyente. Okay, so we'll go to prevention and control. Okay, so one of the control measure is to treat acute cases, because if you treat somebody with an acute case or an active case of malaria, pag na-treated na siya and he get bitten by a female anopheline, you cannot transmit the malaria. It sucks your blood. That mosquito sucks your blood, but when he bites another person, he cannot transmit the malaria anymore. Then the giving of chemoprophylaxis in malaria endemic areas. Then you can reduce transmission by controlling the vector, or that's the mosquito. So we have a lot of ways of controlling the mosquito. Okay, you can use when sleeping, you can use mosquito nets. In the filariasis control program of the government, they give us a repellent impregnated mosquito nets, and they said it could last for 5 years. Even if you wash that mosquito net, the repellent still is in the persist in that mosquito net. For 5 years daw effective yun. And then you can do screening. That's why we screen our houses. It's not only for against malaria. We may not be endemic for malaria, but other vector-borne diseases like dengue, nakakamatay din. Mas grabe din. Okay? So house screening, use of mosquito repellents and mosquito nets. So we have that insecticide impregnated bed nets or mosquito nets. Okay. Then for travelers, assess the risk of acquiring malaria. So you're going to certain area. That's what I did when somebody recruited me to teach at Papua New Guinea. Pag-search ko na ko falciparum malaria. Tapos anira cases, parang na-turn off ako. I might be earning more, a little more than what I'm earning here. Pero sabi ko nilatak, I'm not going to risk my life. Magka-malaria pala ako, parang ganon. So yun, you assess the risk of acquiring malaria if we're going to a certain place. Then prevention of mosquito bites, so you apply insect repellents, wear protective clothing. And one of the activities we did at the tropical medicine course in Bangkok, yung malaria, parang catching the mosquito to determine whether these mosquitoes are an anopheles, the species, and if there were anopheles, if they were malaria, infected with malaria. We did that. We call the exercise or the activity was mosquito baiting. One of you will be the bait, papakagatan mosquito, and then the other one will be trying to catch that mosquito, siphoning that through a test tube. Parang sinusuyop mo masulod dito ang test tube. We did that. Luckily, wala nagka-malaria. Prevention of mosquito bites. So use insect repellents. Okay. And where appropriate one. If you're in a malaria area, prevent mosquito bites by sleeping under a mosquito net. Then mag-long sleeve. Then you take chemoprophylaxis drugs for travelers. Okay, we're almost at the end now. Vaccine for malaria. Is there a vaccine for malaria? Parang COVID vaccine. We have heard of COVID vaccine. There is now a vaccine for malaria manufactured by GSK, GlaxoSmithKline. This was first introduced in 1987. See, before I had the postgrad course in Thailand, waray pa vaccine. They were just still trying to develop a vaccine. I had my postgrad in 84. So yun, the malaria vaccine was introduced in 87. This was funded by the Bill and Melinda Gates Foundation and PATH, a global health group based in Seattle. And after 30 years in the making, the vaccine lowers the risk of getting malaria by 40%. So as of October 8, 2021. So the only approved vaccine as of 2021 is an RTS known by the brand name called Mosquirix. So in October 2021, the WHO for the first time recommended a large-scale use of the malaria vaccine for children living in areas with moderate to high malaria transmission. So the vaccine is Mosquirix. Unlike the COVID one, may Sinovac, may Pfizer, Moderna. So April 25 is World Malaria Day. This is the Mosquirix, the vaccine. So that's, we have to awareness, that's a theme. Awareness, prevention, control, and treatment of malaria. Oh, tapos na pala. 2 hours na. Okay, so that ends. Thank you. Are there questions?
Excuse me, ma'am.
Yeah.
Ano po na, clarification lang po. Ano po na date and lab exam po?
Bi-monthly. During the bi-monthly, I think 25 and bi-monthly. Di ba?
Okay po, ma'am. And up to malaria, both lab exam and quiz po?
Yeah. Ang quiz will be on the 28th. Sa Wednesday. It's a Wednesday next week.
Okay po.
Next week, Monday, you will have lecture with Doc Isaiah sa first hour. So siguro you should, since it's a face-to-face mode ito nga week, you come early. So you can have your lecture 8 to 9. And then from there on, you can have your, you can, start the laboratory. Then pagka 20, quiz kita, the topic from, what's that? Ciliates. Ciliates up to, this one, up to malaria. Quiz. So after the quiz, 8 to 9 din ang quiz. After that quiz, you proceed to the lab. So continue with the, whatever you did not finish, continue, or you can use that as your review. And for my group, that's the time I will check on your manual. Pagka 25, the following week, that's a bi-monthly period na. So face-to-face, one ang bi-monthly. You have to come to school. So we will have the written exam 8 to 9, and then by 9:30, siguro, or 10, we can start the laboratory exam.
Okay po, Doc.
Okay, then make sure, you have your admission slip. Okay, the school requires us to check on your admission slips. Okay, so for the quiz, we have a shorter coverage. The quiz on the 20th. It starts with the lecture of Doc Esquivel. Nag-lecture na kamo with Doc Esquivel on the ciliates, mga balantidium.
Yes po, Doc.
So after that, tapos na kay Casimero, di ba, yesterday?
Yes po.
And then today, malaria. Then on Monday, you will have the lecture by Dr. Isaiah. That's on the Babesia nocema, pneumocystis, cryptosporidium. Okay, no? So So pagka 28, we will have a quiz on those topics. Shorter. So I hope this time you will, score ka mo. Because the last quiz was not, it's the result. We will return to you during the lab period. We will return to you the answer sheet, the one that you answered and submitted to us during the exam, and we will post the key so you can check whether nakamayada kami sa iyo in counting or whatever. So after that, that's the time we will finalize our record for the recording. Because the first result, there was the lowest score was 30 something, 36. Somebody got 36. The highest was 73. One student got 73. The rest mga line of 5, 4. May 75 pala. May 75. One student got 75, another 73. Somebody got 71.
Doc, may I ask how many items po?
50.
50.
50
Okay.
and it will be multiplied by 2 times 2. And moving exam and practical and lab exam also is I already prepared. I prepared 40. So I multiply ito by 2.5. Kaya usually ang una moving exam by table, that's 20 AB. So 20 AB naging 40. So multiply by 2.5 to become 100. So now 40 here, 40 for AB. And just medyo madali in yung first lab exam. I hope you will also score. Everybody will score. Because as we go along, nagtitikadamuan para sa that we're going to study, nagtitikakuri. So this time it's just purely the answers are already there for you, given to you. You have just to choose. But the next time it will not be, it might not be like that. You will be asked to identify. Parang ganun, identify usually may A and B. Pero ito yan lang. It's pure parang nagkuha ka lang ng parang sa lecture exam. May answer na yan. All you have to do is choose A, B, C, D na lang. Okay. Okay, any other question?
I think wala na po, Doc.
Wala na? Okay. Thank you for your time. Maybe we can have our breakfast na ginagurok na takti yan. Okay. So again, see you on Monday after the Holy Week. So have a blessed weekend. Magmuni-muni at the same time basa-basa for the exam. Prepare for the exam. Okay? So God bless everyone.
Okay po, Doc. Alan, Doc, na po, Doc.
Mm-hmm.